go. It is 1:30 p.m. on the 22nd of September 2019, and you're tuning in to Runchatlive episode 34. It's actually a year since I started with episode 1. Just some ramblings about my trip to Kenya and running with a few of the guys out there and setting up a gate lab. That's what inspired it all. So yeah, a year's gone by, and here we are with episode 34. Which again, I mean, I always say it, but I'm really been looking forward to. Actually, I've especially been looking forward to this because for one reason or another, we've had to kind of cancel it a couple of times. And our guest is someone who I've followed for a long time, and he's provided a lot of education and entertainment along the way in terms of online debate. A very big figure, Dr. Derek Griffin, who I'm very excited to bring you today. Again, if you're aware of Derek, then I think he'll be this will be a great opportunity for you to hear him talking for an hour. Sometimes with Twitter and Facebook, it's very difficult to get to discuss something properly with just words. So I'm hoping that, it'll be a really nice opportunity to actually see Derek. If you join us live, which I always encourage, you'll be able to ask some questions, leave some comments. But if you listen to the podcast, then thank you very much for joining us as well and supporting us. That in mind, first of all, let's get some duties out of the way. So as always, our podcast is sponsored by the Brighton Beard Company, www.thebrightonbeardcompany.co.uk. Let's bring a little flash of that up. Yes, there's no getting away from it, obviously, that I am bearded. And these are the guys who I go to for all of my grooming needs. So whether it's balms or oils or brushes or bags to put the lot in, they really are a really nice bunch of people. It's all natural. It's all carefully made. And for me, of great importance is it all smells great as well, which if you have got a beard or you know someone has got a beard, that's one of the reasons we have a beard. It's just lovely to have that waft of fantastic balm oil all day long. It's nice. It's the little things in life which make everything useful. So Brighton Beard Company, thank you very much. They are our sponsors. Also like to mention that Belive Online Studio, who we used to make this recording, have still got the offer I mentioned last week. If you're interested in starting a podcast or interviewing a few guests remotely, so people on the other side of the world, then you want to test it out, don't you? And one way of testing it for free with no credit cards or anything like that is by going to trial.b.live/podcasting. So that's trial.b.live/podcasting. And if you do that before the end of the month, so if you do it in September, you'll get 30 days free trial of the software. And also, just by doing that, your name will get put into a hat to win a Blue Yeti USB microphone. A bit like this isn't a Blue Yeti, but it's a USB microphone, which makes all the difference, believe me, in terms of sound quality, rather than just depending on your laptop. So yeah, great opportunity. Belive Online Studio, I mean, obviously I'm biased, but I use it. It's very simple. You get to use all your branding. You can bring images up. You can have up to 10 guests. It's very nice and simple for the guest. All they need is a Facebook account. I've tried a lot in my time with Skype and Zoom and Google Hangouts, and as far as I'm concerned, Belive TV hits a lot of the things that I'm looking for. So yeah, do recommend you give it a go. Right. Anything else I need to mention? Oh yeah, the last thing I do before I bring Dr. Griffin up is we released news of the student tickets for the RCL International Running Conference coming up October the 30th, 31st. It's only just over a month away. Dr. Griffin, like Dr. Moore last week, are both speaking there, along with Simon Bartol, Christopher Johnson, who else? Mike James, Jack Chu, Derek, Ian Griffiths, Paul Coker, Paul Westwood. Who am I missing out? I always miss out some people. I said Simon Bartol. Anyway, there's 10 of them, and they're great. I've managed to get them all together, which I am humbled by, under one roof. So yeah, student tickets have gone out. We've taken 70% off. I mean, the uptake for students has been low. And then, I mean, I'm not surprised. I know you guys, undergraduates, haven't got much money, but I'm doing this for runners. There'll be news of a runner discount next week. But for the moment, students, it's 69 quid? I think it's £69. It's very cheap. It's a 70% discount for both days. So do go to rcl2019.eventbrite.com and check it out. Even if you're just going to one day, I mean, in all honesty, even if you decide I don't want to stay, £69 is still huge. Each day you'll get 5 presentations from world-class speakers, and you'll get a 90-minute question time. You've got exhibitors there, including Sports Injury Fix, who are a fantastic company to help you with online booking, to help you get found by people looking for your skills. And also Run3D will be there, gait analysis company from Oxford University, with a live demo of their software. They've got a treadmill, the whole shebang's coming, which I'm very excited about. So yeah, come down for 1 day or 2 students. It'll be it's in half term, so you haven't got any classes. It's a huge opportunity. Okay, and that's why I brought the price down to literally cover costs. So do have a look. Right, is that done? Is that done? Everything I need to mention is done. Yeah, fantastic. Okay, so Derek Griffin has been waiting patiently there in the background. If you don't know Derek, then he's a specialist musculoskeletal physiotherapist with a PhD in the area of chronic musculoskeletal pain. He's very, very influential. I think that's the right word. Yeah, I think so. If you follow Twitter and Facebook, then he's a big player in bringing out the research, bringing out the critical analysis of traditional therapies based on what we now know, and things have changed. I've had the pleasure of watching, not heated, but just very arguments which kind of are backed up with critical thinking. It's very rare that you'll catch Derek in one of these arguments with kind of like logical fallacies, or because he knows his stuff. He's a very intelligent guy. So I really do recommend you follow him. He often is challenged by equally intelligent people. So the debate, when you follow Derek Griffin online, is definitely interesting and worthwhile. So I would definitely do that. But I'm bringing him up here for an hour just with me for you to watch as well. So I'm very excited. So I'm going to do that now. I'm going to give Derek a 5-second countdown, and then we'll have to see what he has to say about evidence-based running injury assessment. There we go. Dr. Griffin.
Hi, Matt. Thanks for having me. Delighted to be able to speak with you today.
No, it's the honor is all mine. Thank you so much. I know you're a very busy man. Well, 90% of the time you're out running. And also thank you again. I'll just say it out loud for being one of the speakers at the conference. It's very gracious of you to come over from Ireland.
Yeah, it'll be a pleasure. Looking forward to it. Not long to go now.
There's not. And I can't lie. I mean, last week I said Dr. Izzy Moore, she is the speaker who other speakers are most looking forward to listening to. But I can tell you that you are in position number 2 after Izzy.
It's good to hear.
Is that okay? I know you're not used to being number 2, and that probably inside you're burning up, but I don't know. There you go. You're at the top. So anyway, yes, thank you so much for joining us. I've followed you for a long time, and I really wanted you on this show. One of the first names that came into my mind when I was like, wow, I could actually start introducing some of these people to a larger audience, was definitely you were there. So I'm really pleased that we finally managed to get you on the show. So thank you very much. Why don't you, introduce yourself. Let's start off without me talking for a change. Introduce yourself and tell us what you do.
So as you alluded to, I'm a full-time clinician. So primarily in the area of chronic or persistent musculoskeletal pain, but across musculoskeletal orthopedics. And in the last 2 or 3 years, I'm seeing a larger rheumatology cohort. So I have a very varied role. I see lots of different types of presentations. I also see some acute presentations, but the vast majority of my caseload would be people with various forms of persistent pain conditions.
Okay, yeah. I'm interested. I mean, like I said, you're one of my go-to guys for getting up to date with the effect that kind of modern or contemporary pain science has had on our practice on a clinical level. But a lot of the evidence we've got is from kind of lower back pain that's been used as a sample population in a lot of research. What's the carryover like? I mean, is it fair for some people to say, yes, but just because this has all comes from lower back pain, we can't necessarily translate it or bring it through to when we work with runners? Do you think there is a much of a carryover with what modern kind of pain science tells us?
Yeah, I think the important thing to remember is, regardless of what we're treating or who we're treating, we're always treating a person with pain. And we know, regardless of whether it's an athletic population or a sedentary population, that there's always going to be a host of various factors involved. Now, while the various factors may differ, the underlying principles of assessment will be the same. It's about looking at factors across the biopsychosocial spectrum. So while there's variations, obviously, of course, between these various populations. As I said, the pain is always going to be influenced by a multitude of factors, irrespective of who you're dealing with. So person-centered care is where we should be looking at.
Yeah, definitely. And I remember, I think, when we were talking about what you were going to present at the conference, I think the tagline was putting the runner back into running injuries, which I think was great. I mean, that encapsulates, that could be the name of a book. Or maybe you are working on, I don't know, maybe I shouldn't have said that out loud. But yeah, that encapsulates pretty much everything, doesn't it? Putting the runner back into running injuries.
Yeah, because I think particularly in the athletic world or in the sporting population, there's still a tendency to confuse pain with tissue damage. Now, we know that that's probably a big issue across all populations, but the fundamental our fundamental understanding of pain nowadays is that pain is simply not a good measure of tissue damage. So while injury and changes at the tissue level are important contributors to pain, the ultimate pain experience is influenced by a whole host of other factors. And I'm not sure that we see that type of an approach applied in the sporting world just yet, as we would say as you alluded to, a chronic low back pain population. So I think it's an opportunity for me to see how I feel that we should be applying a similar model of care to the sporting population as well.
Yeah, definitely. It was interesting the other day. I mean, I do some courses for massage therapists, and one of the things I enjoy doing, and the reason I do them, is I kind of like trying to introduce them to things which they've studied which aren't necessarily true. They've ticked the boxes. They've said that, oh yeah, massage helps blood flow, massage does this. They've been taught about getting toxins out of the body, all these kind of things you still need at the moment to pass the exam. But I like dropping a few little kind of, they are probably bombshells, but I try and dress them up a little bit more about our understanding of pain. We do a little section on what we're actually trying to achieve with massage. Are we breaking down tissues, or are we actually massaging the nervous system, and so on? And it was interesting, the last workshop I did, where there was a lady who, she was clued up to the extent that she started talking about one of her clients who suffered from, I think it was a mother actually, suffered from fibromyalgia. And she was saying that she started saying that it was really difficult knowing when the pain that her mum was in her head or when it was actually real. And that was an interesting thing. I thought I flagged that, and I didn't have time on the course to actually go through. I just said to her, make sure you realize that pain is always real. There's no such thing as just in your head or just in the body. But do you think that's still, especially for runners and patients and maybe some clinicians, it's still a danger of separating the two?
Absolutely. So I did some media work there recently for as part of the Pain Awareness Month and the WCPT's physiotherapy day, which the topic was chronic pain this year. And in my conversation with the journalist, I was saying, that we need to get the message across to these people that irrespective of what factors might be contributing to your pain, that the pain is always real. So the danger of, when we talk about factors like stress and the psychosocial factors, the danger is that the message that the patient hears is that this is all in your head. But I think as clinicians, we can use various analogies to try to minimize that risk. So, for example, in the clinic, if we give you an example of somebody that has had, is at risk of heart disease, or has had a cardiovascular event, clinicians will generally talk to these people about the role of various factors, which will include things like nutrition, exercise and lifestyle habits, sleep, and the psychosocial factors that we know linked to heart disease, so stress, etc. No different than cardiovascular disease is real. Just because these factors contribute to pain don't make pain any less real than any of these other chronic conditions that we see people present to healthcare professionals with. So it's around educating them that pain, while it we don't have a direct way of measuring it other than asking somebody to describe their experience, it's not any different than any other chronic musculoskeletal or chronic condition that people live with, there's going to be various factors that are involved in both the leading to the condition and how people need to address it and manage it.
Yeah, definitely. But I think that's one of the, it should in theory be one of the biggest challenges for any clinician these days. I think it's all very well taking this on and understanding implications, but getting that through to the patient without raising that idea, oh, so you're saying it's all in my head. I think that's one of the trickiest things. I applaud any course which manages to fuel therapists with a way of getting past that, because it's tricky, and it'll often depend on the patient in front of you, how you do it, and it's a tricky one. How about oh, go on.
No, I was just going to say there's a lot of work that we need to do in looking at our educational strategies and how we go about presenting some of this new information, especially because some people are hearing this for the first time in the clinic. So if we're really to shift that mindset that, that pain is real and that it can be influenced by all of these other factors, I think it has to start at school level. So there's there's a need for a societal shift in how we understand pain, but to get this information to the masses and to get this information to people before they develop pain would be something really important, but it's obviously a very difficult thing to do.
Yeah, even at school level, it's so true. I mean, even, at parenting level, it's bringing up the kid. I mean, we kind of do it automatically, don't we? It's funny because I've got kids now, 4.5 and 2.5, and every time they fall over, and it happened like for at least 5 times today, when they fall over, straight away we kind of go on, stand up, brush your hands. I give them kind of a distraction technique. So rather than suddenly thinking, it's the whole thing, isn't it? If you look at them and go, oh, are you okay? Then guess what? They start freaking out, screaming, and they're feeling the equivalent of pain. It's an emotional turmoil. But if you just brush it off and tell them to brush their hands and get on with it, it's gone. So we kind of understand with kids that works. And yet at some point during, I don't know when it happens, but suddenly we forget that. And with adults, we don't do that anymore. We kind of start telling them, oh yeah, you've probably slipped a disc, or you've probably done this, or it could be degeneration, or, it's when does, like you say, I mean, well, let's imagine we need a prime minister over here in the UK. Let's imagine you had the spot. How would you do it? How would you start changing this at a basic level?
Yeah, I think there's so many different stakeholders involved that the first thing is to try to get a message to the patient that I suppose the same message from the various people that they end up coming in contact with. The problem that many clinicians have is that, particularly with people with chronic conditions, they're seeing various healthcare professionals and they're often getting mixed messages. So I think even at the undergraduate training, for physiotherapists, doctors, anybody that's involved in patient care, there's an onus on these institutions to be looking at, I suppose, getting these healthcare professionals to understand concepts around self-management and pain management, much earlier in their training, so that when they're eventually seeing patients, that they're giving them these positive messages. But broader than that, introducing some of this stuff into school curriculums, or into an emphasis on lifestyle, physical activity, etc., from a very, very young age, just promoting health literacy and health awareness and getting people active. It's a very complex topic, as you said, but there's so many different stakeholders involved. It's very hard to accomplish that.
Most definitely, which is why I think I celebrate it whenever. I mean, you've been in I think it's the Irish Independent a couple of times, is it now? Or a few times? You've managed to make it through into kind of national press, which I just applaud, because it seems to be such a challenge to get, a learned, up-to-date physiotherapist actually being quoted, as opposed to someone who's part of the problem.
Yeah, well, I suppose I see it as part. I almost see that as part of my role. I think I would like to see more clinicians doing that, because part of my duty is to educate people and to get this information out to them, and running public health campaigns in the national newspaper is obviously a very effective way of doing that. So I would like to see more clinicians engage with patients at a societal level, or not even just patients, but engage at a societal level with the public to try to reshape some of the negative information and to counteract some of this negative information and I suppose the non-evidence-based statements that we often read in the paper.
But do you think the barrier, I was under the impression that the barrier is the people like yourself don't get approached enough, and they'll go for the list. The editor's got a list of people who are ready and to give a little quote. I mean, why? How did you get approached? And Mary O'Keefe, isn't it? How did you two both get approached? What was the situation there?
Well, I suppose it works. It works both ways. I think clearly that is a barrier, but there's also the option for physios and other clinicians. I'll probably say physios a lot of time just
That's
because
okay.
it's the one that comes to mind. But there's still opportunities there to approach local organisations, even not at a national level, but just in your own locality. So to organise information nights for GPs, other healthcare professionals, public talk. So there's other ways to do it that don't involve the media. In terms of our specific engagements with the media, some of those were initially came through Mary, and while Mary was when she was based in Ireland doing her PhD, that's when we did a lot of that work. And it's quite interesting because we've done a few pieces now, but the very earlier piece we did, there was a very mixed reaction. So there was a great clinical reaction, but we got very mixed messages from I suppose the public and from patients, and I actually think Mary collected a number of those responses that we got. So we had to reflect on that, and having reflected on that initial piece that we published, I suppose it may have come across as being a bit blunt at times. This is the danger when there isn't a person in front of you and you're just putting pen to paper. So the second time we did another piece, we were very conscious of making it much more like a story and changing the wording compared to the first piece that we did. And I think eventually we actually got a person with pain to have a look through it and just to kind of reword aspects of it to make the flow better and to I suppose to make it more relevant to the patient population. So it was a learning curve for us for sure, but a very rewarding experience having come out the other side.
I think often the battle is working with the editor. I mean, they're professionals. They know what's going to sell. They know what's going to make the public stay on that page and not just turn it over. So as always in life, yeah, like you say, there's your message, there's the facts, and then there's their skills in being able to change it just a little bit to make it more readable and palatable for the average kind of, John or Jane Doe. But I think that's where part of the problem goes, because the editors will get involved and suddenly they'll give it a headline or a photo. The number of times I see top 10 strength exercises for runners, and they'll stick someone doing a hamstring stretch, with their leg up on it. It's just the stock photo comes out, and then even the subtitle, which the writer's got nothing to nothing to do with, will suddenly change. And it's quite horrific when you get the proof back and it's like, I never said that. What have you put that in for? Did you have complete control over your entry into the paper, or did you get a proof? Were you able to make sure nothing like that happened?
We did for most of those pieces, thankfully. So we were able to write the piece. I suppose it was written by us rather than written by the journalist. The journalist obviously and the editor obviously would have approved it, but we had the opportunity to write the piece, and subsequently they published it. So thankfully we had control over the language that we use. And the more recent pieces that I've done, the journalist was very cooperative as well, and actually really wanted to get an accurate message across. So it was important to the journal, as it was as important to the journalist as it was me, that the message that we're giving across here is an accurate reflection of the science.
I think it's probably like what you just said. You got to get a relationship with the people there. And I write for a couple, or my one magazine now, and I've written for a few years. So in the beginning, there was a little bit of, no, you can't put that down as a subtitle. It totally doesn't mean what I've said, or you can't use that stock photo, or you can't cut out that paragraph because it just ruins the message. But I think when I see other articles, and there's plenty of people online who will very quickly post them up and mock and shame them, but a lot of the time I think it is the editor's fault or the sub-editor's fault, rather than the actual author themselves. It does get kind of bastardized and twisted around before it gets to the general public, which is a shame.
Yeah, and that is a danger. But I think the benefits of getting some of this information out there outweigh the risks. But as you said, it is a danger that the message gets lost or gets changed before it reaches publication.
It's interesting. I think it's a very interesting point that you've said. I mean, maybe therapists could be more proactive in trying to approach papers or approach. I mean, I remember Roger Kerry as well. I think it was the Independent as well, but he managed to get into a international newspaper as well. I think he had a piece on running shoes, and he came. I mean, they quoted him saying, "I'll run in a pair of £20 shoes from Asda or something," or But it was an isolated piece. I think that was about probably 5 years ago. And again, I applauded it, and it should have sent shockwaves through the whole of the media. But I don't know, I haven't seen anything since. So I imagine there are barriers. I don't know.
Well, I think clinicians have to be more proactive. We shouldn't need a World Physiotherapy Day to suddenly start educating the people about chronic pain. If people can do it on that day, that can be done on a more regular basis, and not just chronic pain. I don't mean that it's just chronic pain we need to be educating people about, but health literacy and public health awareness is a huge topic, and physiotherapists and other clinicians, we play a huge role in health promotion, and the only way we're going to help that is to be going out there into the community and engaging with the community and keeping people healthy, not even just patients. We should be interacting with these people before they become patients.
I think it's a good point. I think some very valid points, which I never planned on talking to you about, which is the thing I love about getting someone live and talking to. All these sort of things come up. So yeah, some very good, interesting points there. Let me just say hi to Mike James. He's in the house. Hi, Mike. How you doing? And Chris has joined us, and Gustavo Torres. It's ironic as well. Again, it's just confirmation bias. The people who watch this show, for example, are people who I know live and breathe what we're saying anyway. I wish we could get someone in there who was actually like, well, what are you talking about? Or would start arguing or defending. It doesn't happen. That's one of the tricky things as well, isn't it, with social media? You're just rubbing it.
We all bring our biases to the table, and it's a very difficult thing to get around. And we'll be attracted to the information that fits our narrative and fits our bias, and trying to take the other stuff on board is obviously a challenge for all of us.
Mind you do sometimes like to hang out in places where that most of the people in there are not going to be on your page, maybe, or not on the same side.
Yeah, I suppose, a lot of my work is in chronic pain. I take a huge interest in a lot of other areas as well. So I read the literature quite widely, and I think that has been very helpful, because reading some of the other areas that you wouldn't necessarily directly work in just give you that extra bit of that extra bit of information is never wasted. It's never lost, and it just sharpens your clinical decision making, because patients are different. They present with various combination of things. So contrary to what I suppose and again, this is the portrayal of how some people come across on social media, is that we're in a silo and we read a specific branch of the literature. But for someone like me and many other clinicians, I would read a lot. I would read the biomechanic literature. I read the exercise literature quite a lot, the psychology literature, and it's about just keeping an open mind from the various disciplines, and how we put all that information together when the patient is in front of you is the bit that's important.
That's cool. Yeah, definitely. Well, like I said at the beginning, I totally recommend that therapists follow you. And I mean, if you want a blueprint, not again making your head too big for the screen, but if therapists want a blueprint on how to stay up to date and how to debate and talk, and because I noticed as well, like you can get in some quite heated arguments, but you stay so polite and educated, and you back it up with concise. It's good to see. I like it, me personally. I think Mike and Chris as well. So thank you anyway. Right. We labeled this episode as, we're going to obviously want to appeal to runners in particular. You're a runner yourself. You've got loads of experience. So to narrow it down, we're going to talk about running injury assessment. So runner comes through the door. Let's start off. I remember I saw a nice thing which you wrote or spoke about somewhere else about yellow flags, which is yellow flag still a useful thing to talk about?
Yeah, I think so. I think it's a useful concept, especially for students and maybe less experienced clinicians. It gives a framework for something that they can need to look at as an important part of an assessment.
Yeah, I think so. I mean, that's something I definitely mention when working with people who've done basic courses, because I'm not sure in physiotherapy, maybe it comes up as a standard part of the lectures and stuff, but I'm not quite sure it gets talked about enough in other professions, or definitely not sports massage and sports therapy. But I like the comments I read about you. You were talking about noting the areas on a body chart that a patient marks. And it was interesting because in my time, I always used to get annoyed when receptionists in the clinic would hand the sheet to the patient to fill out whilst I was kind of finishing with the last patient. It was like, no, I want to fill it out because I want to have a conversation with them. But then you brought up the idea that you like the patient to fill it out because you like to see where they note on the body mark, maybe kind of how they note it and that sort of stuff, which opened a new dimension to me. I thought, actually, the guy's got a point. Give it to them, because again, you can tell a lot of information by what they put and how they put it. So tell us a little bit about that.
I suppose to begin with, I think a lot of that stems from, there has been some literature, which I can't recall off the top of my head now, that looks at a comparison when the clinician fills out the body chart and the patient fills out the body chart, and how they actually compare. And there's often quite a discrepancy in what they mark. So that probably tells me that, when we fill out the chart as clinicians, that we're bringing our bias to the table rather than giving the patient an opportunity to express their pain in using a body chart. So that, I suppose, that's the first reason. But the second reason is that we know that the spread of pain, or the number of pain sites, is actually quite an important prognostic measure in pain. And the prevalence of multi-site pain is actually quite high. So particularly for disabling or persistent pain states, it's actually quite rare that pain stays in the one area. It's much more common that people report multiple pain areas. And we know that the more pain areas that people report, generally that's associated with higher rates of disability, poorer prognosis, and there's a higher psychosocial burden associated with that. So a lot of information can be gained from the body chart. And I think it's important to point out here is that it has been shown, particularly in David Coggan's work, who's done a lot of work on occupational related pain, and he has shown that the prevalence of multi-site pain is much higher than we would expect if this was a chance finding. So it's very unlikely that these different pain areas are independent statistically, that they almost reflect a phenotype of, or a distinct clinical phenotype, that we shouldn't see these various pain problems necessarily in isolation, that they together reflect they're part of the pain state. Now, that doesn't mean that the physical factors aren't relevant here, and I think that's the message that often gets lost in all of this. While physical factors and tissue-based factors and peripheral nociception are probably relevant to some degree in most pain states, if someone presents and they have multiple pain sites, all it suggests is that there are other factors that are probably putting these people at risk of pain in general, rather than seeing it as, distinct injuries in different parts of their body, that there's some common factors that might be accounting for part of this variance.
Yeah, no, very interesting. It's almost like taking, because traditionally you'd put body charts into the objective part of the consultation, but by looking at where they fill out, how they fill it out, how thick the line is, you're actually putting it more into the subjective as well, aren't you? Giving them a chance to express themselves and give you more valuable information. I think it's great. Yeah, it makes good sense. What else, for example, let's imagine that somebody is watching this whose ears have suddenly just pricked up. They've gone, oh, I never thought of that. Tell me more about this subjective assessment kind of thing. Because I think it sometimes, especially for, well, I'm lucky because I work in private. So I'm generally, for the first appointment, I've always got an hour. It's calm, peaceful. The patient's ready to talk. For a physio, I guess, who's only got 15, 20 minutes, both the patient and the physio aren't quite happy to talk so much. But tell us some of the other things which you think are kind of like hugely important factors to address within the consultation.
Yeah, well, I suppose I'm in a similar position in that I have an hour with every new assessment, and to me the story and the subjective history taken is absolutely crucial, and I suppose I've done a lot of work. I've done a lot of work teaching as well and interacting with students, and I suppose the traditional model has been is that the subjective has become a very kind of a formulated way of gathering information, and that we get it down in 15 or 20 minutes and then you move on to the subjective assessment. But I think what you'll actually find is with more experience, the subjective part actually becomes longer. Or it becomes much more intertwined with the objective assessment. I don't see them as distinct. So when you're examining somebody, objectively, quote unquote, that you're still talking to them, you're still interacting with them, you're looking at their reactions, their behaviors, you're still interacting with them and chatting to them and asking them these various questions. So that's the first thing. I don't see them as very distinct. But if we take a runner, for example, so to try to make it relevant to people listening on this podcast, so as part of the subjective history, I'm obviously interested in like what brings them to the clinic, so just giving them an opportunity to discuss the issues and ultimately why they're sitting in front of me, and that may be pain, but more often you'll find that again with the runner it's pain that's preventing them to run, or it has had a negative impact on their performance. So we need to be very clear from the beginning and what their primary concerns are. Then we would look at, what might have been some of the factors that contributed to that. So we're all very familiar these days with the concept of load monitoring and load management. So, I'm very interested in looking at what changed in the lead up to this current problem. So what were the variables that changed? And within this, obviously, we're looking at the running related variables. So I'm interested in their mileage, changes in speed work, any change in their training that might have occurred in that typical 4 to 6 weeks. I suppose assuming here that this isn't an acute kind of a traumatic injury, which the vast majority of running injuries aren't. That's slightly different. But I'm looking at what changed in the last while, and this all comes under the umbrella of external load. So these are the things we can measure: how far, how long, how often, how fast, what terrain. So the very concrete objective stuff. And very often you'll find that will have some clues as to why they're in front of you. They'll have been a change in volume, and perhaps a change that they haven't been conditioned to be able to adapt to, and the system has reacted, and that may be injury or it may be and pain. But I think the bit we tend to forget, I'm also interested in the internal load, and we can put a different term on this if we want. We can talk about sleep, the psychosocial factors, so their mood, their life stresses, all of these other factors that people have to deal with on a day-to-day basis. Runners are humans at the end of the day. Even at elite level, when it's their profession, there's still going to be outside influences. They're going to have, there's the mental health aspects, there's their sleep, there's their nutrition, their medical history, all these other various factors. So you can have two similar people. You could put them through the exact same training program, but the adaptations or the physiology underpinning this is very different, because all of these other factors that we associate with their internal load are different. So it's not enough for me to have an idea of how much or how fast these people are running. I need to know how well their various body systems are able to cope with this. So, what their strength and capacity is like, but how well they regulate their mood, how well they sleep, what they eat, what their nutrition plans are like. So there's a whole host of other factors that perhaps in the running world have played second fiddle to the more traditional stuff around biomechanics and simply looking at the external load and the physical factors in isolation.
Yeah, no, very interesting. Well, so much in that. I love the way you say that the subjective and objective actually shouldn't be totally separate. That even if you're doing a traditional assessment test, you're not just looking at what degree they produce, you're looking at how quick they are to do that movement, or any fear involved, or any expectation or belief they might have about doing that. It's a great message there.
And the other thing, that concept also helps when you're talking about some of the psychosocial factors. So, when you're looking at how people are moving or things like that, I would often in the middle of that conversation just kind of ask them about something like any life stresses at the moment. So it becomes a much more informal way of asking these important questions rather than a very formal interview style type assessment where you might get a little bit of resistance. Whereas if it becomes more informal part of a conversation, then they don't see it as something that they see it a little bit differently.
Definitely no. Mike James just asked a question. I'll read it out so people on the podcast can actually see it as well. Mike, the endurance physio James, says, with students and less experienced therapists, the more structured, subjective history taking is understandable to help ensure important things aren't missed. Does Derek have any top tips to help this population of therapists become more free-flowing, so to speak, in their subjective history taking? Did you get that? Does that make sense?
Yeah, hi to Mike. So I think that's very relevant, and I think that's it's understandable. Clinicians, they're very new to this, and it is important that we're screening for things that are a little bit out of the ordinary. So we're always vigilant of these, the small percentage of people where they will present with pain, and unfortunately it'll be attributable to something serious or an underlying medical condition that's not diagnosed. So it's important that we have a mechanism, particularly for less experienced clinicians, that they don't miss out on these factors. But I suppose it's always a challenge. How do we get students doing it in a less structured and I suppose a little bit more of an informal manner? But as at university level, I think there's room for looking at like motivational interviewing type skills, the so-called soft skills that haven't traditionally been taught. We also need to be, I suppose, pairing the students and the more inexperienced clinicians with more experienced clinicians. So actually giving them the opportunity to be mentored and to observe a lot of this. When I was doing my PhD, every Friday afternoon, I sat observing in a pain clinic. And that might have been 25, 30 patients in a busy outpatient clinic, and just that experience of sitting back and seeing other clinicians in action, but just having the opportunity to just listen to patients. And I wasn't asking the questions at that stage, and it gave me an opportunity to just listen and be able to reflect. So I think the only way the students can develop is when we put them in touch with clinicians and in environments that are conducive to allowing that type of an approach to happen. Too often they're into a setting or into their first job, and they're maybe not getting that type of mentoring that they require to develop these skills, because it is a skill and we're all developing it all the time. So the answer to that question is multifaceted, but good mentors, good strong mentors, and some of those so-called softer skills around interviewing and listening skills developed at a much earlier age or earlier part of the curriculum, I think is a crucial bit of that.
Yeah, that's a good answer. Hi, Mike, I hope that helps answer your question. I mean, I felt that maybe I got into therapy because originally the first kind of thing I really enjoyed, and now I've gone back to it, is teaching. And one of the things obviously you learn about being a teacher or a lecturer is kind of making sure you don't do too much of the teacher talking time. It's all about, especially when I was teaching English as a foreign language, you're always trying to elicit the answer from the patient, because that's the way people learn languages. You don't just want to translate it. And I always think the carry through from that, just even in any topic, allowing the student to reach their conclusion, allowing the student to give you an example or fitting what they've just learned into context, all these basic teaching skills translate really accurately through to when you're trying to help somebody in pain, I think, because again, you're allowing them to come up with the answers. What does the pain mean for them? How would they describe it? What do they think the issue is? But I don't think, again, on a lot of the things healthcare practitioners are taught, again, you're not brought up as a teacher or an educator. You're brought up as like an operator as opposed to a facilitator, where you've got the magic hands, you've got the skills where you're going to fix somebody. So I guess that, we got to teach therapists to become teachers and educators as opposed to kind of just technicians. Does that make sense?
Yeah, I think I like that whole concept of almost clinicians acting as a coach.
Mm.
It's about listening to the individual, and it is our job to kind of help them piece the various bits of the puzzle together to make it a bit more sense to them, but then kind of plan that journey in terms of what we're going to do to help them better cope and manage that.
Mm. I remember, I mean, when I did a while back now, but when I did the kind of I think it's UK Athletics at the time. I can't remember, they've changed their name now, but the coaching kind of certification and that, a lot of it was teaching you how to be a coach. It wasn't teaching you about different types of runners or foot strike, all these things. It was showing you how to demonstrate, how to make sure that everyone can see, everyone can understand, getting the runners who you're coaching to kind of repeat what you've just said, the instructions, or giving visual demonstrations. And again, it made me think, this is great. You're teaching coaches how to be coaches, regardless of what you're actually, the information you're giving. You're educating people how to be educators. And I get the impression that with a lot of the CPD that goes around and the courses that are offered, and I read all about what's being offered, and there's not enough of this. We're expecting clinicians these days to be educators, but how much CPD is out there helping clinicians become educators?
Yeah, it's definitely a challenge, and again, we need to be promoting more of that, and maybe even promoting it within the clinical setting. I go back to this idea of other clinical mentors and other people that have experience in this area, and just observing and getting people to observe and critique and just having a very open relationship that you can offer some advice to some colleague, but your colleagues can equally look at what you're doing and perhaps give their input as well. And you have to have a good working relationship between these various healthcare professionals.
Yeah, definitely. And there's another question here from Daniel, osteopath from Glasgow. Let's put it up. I'll read it out for people who listen to the podcast. So Daniel Gerber says, does Derek go into nutrition plans with lower end newer recreational runners? Does he advise or does he refer on? So that's going back to what you're saying about making sure you look at the internal load. Is it something which you feel you're able to comment on, or do you feel that's kind of not your area and
Yeah.
you refer? What do you do?
Well, yeah. Look, it is in my area, but I will generally ask them about their nutrition just to get a sense of what their nutrition entails. But if I feel in any way that it might be a significant contributing factor, be it they be underweight, or that just subjectively they're reporting issues with appetite or food, then in those situations, absolutely to refer to a registered dietitian that can give them more specific advice. So I suppose to answer Dan's question is, I don't. I bring up the idea just so I'm aware that this is something that might need to be addressed, but it's not something that I directly I engage the patient with. No.
Yeah. So in other words, it's a conversation you've got to have to raise any potential red flags, and then have that kind of referral network to be able to pass it on to somebody who, again, it's so tricky with referring, isn't it? I guess in time you surround yourself with people who you know on the same page, but nutrition itself and dietitians, there can be a lot of variance, can't they, in what the advice they give.
Yeah. So, and again, I suppose that's just time developing working relationships with various healthcare professionals, and meeting up with these healthcare professionals to discuss the various concepts and have open conversations about where you're coming from and what specific advice or what you're looking for from that athlete. So there needs to be a very clear agreement between whoever you're referring on to and the referring clinician.
Definitely communication. Who would have thought we need to start talking to each other? What a crazy idea. Okay, so we've kind of talked, we could go into great detail about other things, about the importance of the subjective assessment and how I understand completely what you're saying, whether you shouldn't separate the two. But how about, I mean, it's interesting when you look at traditional objective assessment and some of the tests we use. I'm very interested to hear what tests you do still use out of the many, many, many which were taught and are still taught. Obviously, it'll depend on the runner in front of you, but have you got some go-to ones which you'll always use?
Yeah, obviously it's very much dependent on the individual. I suppose the important bit is any tests that we do use, and even the ones that have more validity and reliability around them, is that a test on its own is never part, or it never gives you the diagnosis. The vast majority of times it's a combination of this story and the clinical history, and the tests are used as a way to confirm that or not. I wouldn't say necessarily I have general go-to tests, but in runners we're generally looking for that they have an adequate capacity, or an adequate, they have the adequate physical attributes required for the level of running that they're actually doing. So that will obviously differ depending on, if it's a high level elite marathon runner versus if it's somebody that wants to run 5K 3 times a week. So, I would never lose sight of the importance of testing, I suppose, what I would refer to as the basics, so that there's no obvious impairment that's going to have an impact on their ability to do this. So, looking at, for example, calf strength, or, their ability to hop on one leg, for example, might be some of the more routine tests that I would do with runners. I think a range of movement screen of the lower limb is generally a very valid thing to do, but not over interpreting somebody that might have a little bit of, restriction of their hamstring length, for example. And we need to let go of these notions that there's an ideal, and that if somebody doesn't fit the ideal, whether it be hamstring flexibility, ankle dorsiflexion range of movement, that suddenly we can't assume that that's the reason they're in pain, or that's going to put them at risk. But again, with any of these tests, you're going to have a story behind it. You're going to have the patient in front of you. You're going to have a lot more information to judge whether those impairments may or may not be relevant to that individual.
I find myself more and more, especially when I'm writing about it, I'll say, yeah, we do these tests. We'll check range of motion, dorsiflexion, hamstrings, and hip rotation and stuff. But we're not going to draw any massive conclusions from it, and we'll kind of note it down, and it's part of this jigsaw, etc. But I do wonder whether a time will come where we realize that a lot of the time later on, we're not really drawing on these tests for anything. They seem to be disappearing more and more. I use the test to rule out stuff, like you say, jumping up and down on the spot, maybe to check it's not something where we're going to have to say, right, you need to really pull back the volume or stop running, like stress fractures or something. But in terms of if they just come in pain, it seems that these tests are becoming less and less relevant. Symmetry, for example, I mean, a lot of the tests we do are checking for symmetry, and it still confuses me as a clinician, because on the one hand, I'm saying we shouldn't expect runners to be symmetrical, because in nature, symmetry doesn't really work. Even in the elites, we don't get this symmetry. And yet a lot of the tests seem to be check the left, check the right. Are they symmetrical? If you take that away, it seems like you're not really left with much.
Yeah, and again, I think we have to be careful with any causal reasoning here. The problem is, a comment that I often say is that as clinicians, we're generally inherently biased, because we see people with pain that present to the clinic. We don't see people either without pain that have all of these impairments that we don't see in the clinic, or people that have pain and we still don't see in the clinic. So they appear to be functioning quite well. So we've got to be careful that the population that we see, it's very easy to make causal claims about, their foot posture and pain, or their hip range of movement and pain, when somebody could have a similar range of movement, or have similar deficits, so to speak, and be running pain-free or perfectly fine. So you'll often find in the subjective, if somebody has a very rapid or a sharp increase in their training load, or it was very clear that life was very busy at the time and there was a lot going on, and they weren't recovering well and they were run down, sometimes the answer is very obvious. Or at least, there's a collection of factors that, when I say obvious, we still have to be careful that we don't assume there's a one-on-one relationship between these things. But I suppose the story will fit with, why these people might be injured. And in those situations, I think putting too much emphasis on these so-called special tests is often making the athlete more vulnerable, because now, if we had just addressed the loading factors and their recovery strategies, and reassured them, versus identifying all these impairments that they probably never knew they had, and now suddenly they're this athlete that's full of broken parts that need to be fixed.
Yeah, I mean, I wonder whether like you said at the beginning, where we're biased and we only really have people coming in pain, so we don't see other people. I wonder whether it would be interesting if clinicians actually took the time to make a little record of, for example, people that walk in with, I always use with my students, one shoulder higher than the other, but they've come in with an Achilles issue or something, because just to write that down, just to note it. Oh, today someone came in like that, but it wasn't with a shoulder issue. And then over like a half a year or something, just to have a visual kind of like a useful bit of data to show how many people really are asymmetrical, how many people might have, I don't know, maybe it's a strength thing as well. Maybe we might find out that people come in and they've got massive tonicity in their calves, or maybe the calf which is really kind of hypertonic and is actually the one which is fine. It's the other flaccid one which hasn't got any tone, which is actually painful. I wonder whether the change or shift could come from actually therapists taking a little bit more of the incentive, kind of by noting themselves down, having a little book, because that could be some really interesting data. If all the therapists over the country started doing that and somehow it's pulled together, that could produce some very interesting reading, I think.
Yeah, and I think that's the whole notion of reflective practice, that we should be reflecting on our practices, and particularly bits of the assessment that go against what diagnosis we're putting on the patient. So they'll always be parts of the assessment that will fit with what we think is going on, but it's equally as important to be very much aware of all the other factors. As you said, they might have the same restriction on the other side and they don't have pain on that side. So any attempt to reduce a very complex phenomenon like pain and injury to single factor thinking is never going to help. It's very appealing and it would be lovely if it worked that way, but it's just much too complex than that. We even see it with training loads, even the more obvious things, that some people can just get away with, spiking their training a little bit more than somebody else that does very little change in their training load. So even with the more obvious stuff, it's often not that obvious at all, that there's a lot of factors that we probably don't consider that we should consider, and probably some unknown variables that we're not aware of yet that maybe over the next number of years that will become more enlightened about. But the complexity of injury, and even in sport, is a lot more than it's simply down to a restricted ankle or a tight hamstring or whatever it might be. And just briefly on that, you'll see some. I'm trying to think of the term that they use, but it's basically looking at complex systems as a way to explain injury. So complex systems basically mean that if you try to reduce it to any of its component parts, the outcome is different. So injuries are probably emergent in the sense that no one factor is directly causal of the injury, but it's the interaction of something like training loads and sleeping habits and life stress and fatigue and recovery, and all of these various factors are interacting in non-linear, non-predictable ways to ultimately lead to the problem.
Yeah, definitely. I can't remember. I'm not sure if it was. I think it might have been Adam Meakin's. Maybe it was on his podcast. I can't remember, but they were I think it was him and Greg actually talking about the difference between complex and complicated, which I think now and again, I mean, me personally, but I like words. I enjoy separating the meaning of words, but I think it's useful for a therapist who's embarking on this kind of critical thinking and this new way of thinking to actually separate words, the same as you would separate, for example, pain from injury, which a lot of the time you might think is synonymous. But complex and complicated, I think, is good. I think they compared it to like a car engine, which is complicated, but if you've got the manual or you're trained, you can always fix it because it all works in a certain way. Whereas the human body, and I think they used it in the argument that we shouldn't compare ourselves to cars, the human body's complex, which is different. It's got all this interactive stuff, and there's not like a manual where you can just take this out and twist that and tighten that up. It's a really useful distinction, I think. Yeah, does that make sense?
Yeah, and I like, it's not, the interactions are non-linear, but although it's quite complex, and we probably, even in the clinic, we won't necessarily fully understand how all of these various factors are interacting, we can still look at ways of improving somebody's sleep, for example. We can still educate them about their training volumes and progressions of training loads. The body will do its own thing, but when we address these various components, the interaction between these factors obviously will change as well, and we're having some influence over that without necessarily needing to know exactly how these factors are interacting.
Definitely. So you can make someone feel a hell of a lot better and get them back to running, and you might not for the moment know exactly how you did it, and you don't have to.
Yeah, we know the various bits that we changed, but we don't really understand how all of those things fitted together to give us the outcome.
Yeah, it's interesting. And in the meantime, we kind of use research and evidence-based practice to try and work out how things work so we can make them better. But I think that's a useful take-home message for therapists as well, to help somebody. You don't have to label what's going on in their knee. You don't have to say exactly what tissue is being affected, because, like you say, it's a multifactorial thing, which you kind of need to know about. And you can have someone walking out, getting back into running, being very happy, and they don't really know what happened, so no, very good. I can't believe it's 2:30. That has got to be the fastest hour I have had with any guest so far. I'm quite taken aback. I'm almost checking my phone to see that my computer hasn't gone wrong. I wish we had another hour. We haven't though. But anyway, there's so much more I want to ask you, but we'll save it for Brighton. Right. I can't believe I'm having to stop this conversation, but what have you got coming up, Derek? What's in your life? Let's come away from assessment and running, and what have you got going on?
Yeah, so I suppose outside of my work, most people will know that I'm a competitive long distance runner. So I'll probably wait until early next year to run the marathon. So I'll work a little bit on the shorter distances between here in January or here in December, just to vary things up a little bit. Again, work on probably some of my deficits, and in preparation for to try to run a PB as in early next year, probably March or April. I'll target a marathon around that time. So again, it just requires a huge amount of preparation to run the marathon. I'm generally quite competitive, so I could run a marathon sooner, but I have a goal in mind, I have a time in mind, and if I'm gonna hit that time, then I have to put my resources into that and plan ahead for that. So it takes a bit of discipline. I'd like to be running every weekend. I'd like to be racing every weekend, but again, it's impossible to juggle everything. So the target is a good fast marathon in the early part of next year.
Yeah, I think the last time we were supposed to speak was like the day or a few days after London Marathon. London Marathon went quite well for you this year, didn't it?
Yeah, I had a really good run in London. A lot of work went into that. Together with my coach Andy, I worked a lot on my speed work leading up to London. I was very consistent in my training, which I think was the big thing. And having ran the marathon many times previous to that, I've had a lot of difficult marathons. I've had some really good marathons, but the difficult ones have been instrumental in just teaching discipline and teaching respect of the distance. So I think in London, everything just came together. I trained really hard. I trained well consistently, but I had respect for the distance. I understood what it involves to race the marathon. My pacing worked. The weather was good. So everything just came together in April, and I was very pleased with that performance.
Cool. I love hearing about your running exploits, and I think we couldn't argue that it helps if you're looking after runners to be a runner yourself. We don't have to be as good as you, fortunately, because I'll never get there. But would you agree, if you're going to help a runner, it's useful to have that background where the challenges, how difficult it is to put theory into practice sometimes?
Yeah, I especially because as a clinician, I'm going to be seeing runners we see them when there's an issue. So when they have pain or when they're injured, and that has a profound effect on their general well-being. For the vast majority of us, the running is more of a hobby than it is. It's not work. So we use it as much as a coping strategy, as a way to manage our life stress. And I think clinicians again need to understand this. When you take somebody's coping mechanisms away, for them it might be running, you often remove them out of their social environments, their mood changes. It's much more than just running. And I think Tom Goom had a nice picture up on Twitter recently about just the impact of when we stop people from running, and the negative effects that has. So as a runner myself, I can empathize with these people as how it feels when, for whatever reason, you're just not able to run.
Definitely, it's a very big one, and something you could probably put a whole episode about. Well, look, Derek, I'm sorry, I really feel bad that the time has beaten us. It's gone so quickly. You're coming down to Brighton. I'm very excited about that, along with the other 9. It's going to be fantastic seeing you all interacting together. Is there people have you met people? Simon Bartold, Jeff Asculi, have you had a chance to meet them in person, or?
I don't think I've actually met any of the people presenting, but these are all hugely influential people in the running world and just in the performance and the clinical world as well. So it's a huge learning opportunity for both, I think, for all the speakers as well as it is for the participants. And all of these people that I've had the pleasure of interacting with online, they're all very reasonable people. They're all very genuine, sharing their information, with the common goal of improving the health and the performance and well-being of runners. So I'm really looking forward to it. There's going to be a huge opportunity for networking between the participants and the speakers, and it just provides a forum where we can have genuine discussions in a non-structured or in a very informal way, and people have the opportunity to talk about topics that, as you said, sometimes we can't talk about properly on social media just because the limits of social media.
Definitely. I mean, that was one of it's ironic slightly, coming out of a podcast, it fueled my kind of desire to actually increase face-to-face participation, and that's why I did it. I love doing podcasts. I love chatting to you, and it's very, very useful being able to chat to somebody remotely like this. But I do worry sometimes that I see a lot of workshops and a lot of education now being done remotely because it's so much easier. I watch things like Black Mirror on TV, and I'm scared that that's the way it's all going now, that we'll lose that face-to-face contact. And I still believe that there's a massive element you take away when you just rely on internet and online. You need that touchy-feely, seeing that person, hearing them, that face-to-face communication. So yeah, I'm very excited to see you all together. I think it'd be a great event.
Absolutely, yeah, I agree.
Right, dude. And you're going to be talking down there about, do you remember the name of your presentation? I think I put you on the spot, Steve.
Yeah, I think it was pushing the runner back into running injuries.
Oh, did we go with that in the end? Oh, fantastic. Okay, so that's nice.
No, I think we did. Yeah,
oh,
yeah.
Fantastic.
And it's exactly, I suppose, of what I spoke to you about today. It's about seeing people for people, and not it's not a body part irrespective of who you're treating.
Fantastic. And I'm particularly looking forward to, there's a 90-minute Q&A session where all 10 of you will be up on stage, and we'll be taking questions from the audience, which will be very good as well. Although I think most of the speakers are on a similar page in terms of, like you said, genuine and responsible experts in their fields. I'm hoping there's a little bit of debate and different stance points. And I think there will be. I think we've got a little bit of, there'll be some interesting different ways of seeing things, so that should be good. Well, look, Derek, thank you so much for your time. I really appreciate it. What I'm going to do is I'm just going to kind of send you back down to the lobby for a second. I'll sign off here, and then I'll come back down and join you and say thank you again. Okay.
Thanks for having me, Mark.
No, thank you, Derek. I really appreciate it. I'll see you in a second.
Thanks.
Right then. Wow, I swear that was the quickest. I can't believe it. I was looking down the clock thinking, where are these minutes going? That was really good. I really enjoyed that. I need to come down. I think I need to go for a walk. That was great. I hope you enjoyed that as much as I did. If you did, then make sure you do leave some comments. If you don't follow Derek already, then please try and do so, especially on Facebook. I think that's worth seeing, very active, maybe Twitter as well. And if you enjoyed it and you want to communicate with him, then yeah, check him out, send him something. Very down-to-earth guy who very much likes to chat and talk to people. So yeah, feel free to do that. And as well, also with us, if you enjoy the podcast, as always, do please leave some comments. You might have heard it from other places, but the success of the podcast really does depend on you liking us, leaving a rating and a review on iTunes. If you're an Android user, then I'm afraid you have to go to iTunes. You have to open up iTunes on your laptop. And that's the only way you find Run Chat Live, and then you leave a nice rating and a nice comment. If you're not going to leave a nice rating or comment, then ignore this message. But if you're going to leave something cool, and basically what that does is it just means that Apple chooses to advertise our podcast and it gets through to more people. If you use an iPhone, then that's great. You can do it straight from your own iPhone. There's normally got an app, and it just allows you to leave a review and a rating. So yeah, please do that. It really helps. I see in the background the ratings going up and down the UK and the States. The other day in the States, we were number 5, which was like, wow, the 5th running podcast in the States. That was lovely. And that was purely based on a few people leaving reviews. So yeah, even grab your mate's phone whilst they're not looking. Just grab it, download the app, and just subscribe, Run Chat Live whilst they're not looking. They won't know. Be great. You're allowed to do that, I think. Anyway, right. That's me signing out. I hope you enjoyed it. I won't be here next week because I'm so excited, I forgot to mention it, but yeah, I'm off to Tunisia to cover the 100K Ultra Mirage El Jarid, where Star Wars was filmed. I'm very excited about that. I'm not running it. A few people said, oh wow, I'm really impressed. No, I'm not running it. Maybe next year, a bucket list thing, but I'm going over just to cover it, hopefully do a few interviews with the guys over there, see a few faces I've met already. Elizabeth Barnes, who was on one of the episodes of Run Chat Live, she will obviously be very keen to win it again this year, and a host of other runners there I'm very excited to meeting in person. So yeah, I hope to produce something from there. It depends on internet connection, but I'm pretty sure from my hotel room I should be able to bring you something very interesting with some of the runners. So yeah, look out for that. And otherwise, after I come back, we'll be continuing with some great guests, great chat. So do subscribe and like us. Thank you much for joining us. My name is Matt Phillips, and this has been episode 34 of Run Chat Live. Thank you. You're listening to Run Chat Live podcast, putting the evidence back into running injury and performance.